Hi guys, my name's Abdal, okay? And thank you for coming to the seminar. So I'm going to try to go through rehab and injuries, hopefully over the next 40 minutes. If it's a lot to take in, so if you have any questions, just ask away, okay? So I'm injured, now what? It's probably a question that's gone through most of our minds, whether you're a coach, you're an athlete, or you're just interested in barbell sports, okay? First, I'm going to introduce who I am. So I'm an orthopedic surgical trainee. So in simple terms, it just means I fix bones for a living. Okay. I did a degree in sports and exercise medicine as well, ranging in modules from biomechanics to rehab to clinical exercise prescription. I then, during lockdown, because I was extremely bored, I started doing rehab for athletes. And then I became University of Nottingham's rehab coach. And then finally, Big Up Barbell Coalition became their rehab coach. So why? Everyone has a why. What's mine? This was my short and sweet powerlifting career. No impressive numbers there. But I was always getting injured. Okay, so I became my own guinea pig. And I started learning kind of how to rehab myself. I then started coaching and handling several national and international athletes. And I realized that, you know what, I quite enjoy the coaching aspect of things. And you know the joke they always say, if you can't do, you teach. So that's why I've gone that way. And then I did my extra degree and realized basically how poorly we understood pain and rehabilitation in the UK. The US is miles ahead of us. Okay, they really have a good grasp on pain and rehabilitation. Hi guys, just come in. We're just starting. So yeah, so basically our understanding of pain was really bad in the UK and really good in the US. So my aim was to introduce research-driven rehab in the UK. And for all you OGs out there, you might know who barbell medicine is, and I would love to be one of those guys. That's me superimposed on one of their guys. So what I'll cover, so you guys have like a leaflet right next to you. You can open that up. It looks really intimidating, but don't be worried. I'll try to break it down into digestible core principles for you guys to take away, whether you're a coach, whether you're an athlete, to implement into your own training. I kind of call this my 4 pillars of rehab. I had to give it a cool name, you know, so I could coin it myself. So 4 pillars of rehab. Lovely. Oh, so guys, when you get injured or you know someone who gets injured, what do you think about? What's the first things that go through your mind? And if you don't answer, I know a few names of a few people. I'll just pick on them because I know they've been injured. So what do you guys think of when you're injured? Recovery. What do you mean in recovery? Like how fast you're going to recover? How are you going to recover? Is that what you mean?
Yeah, how I'm going to recover.
Yeah, how are you going to recover? Good, yeah. I'm sure that goes through everyone's mind. Anything else?
Panic.
Panic. Who said that?
Panic.
Panic. What do you mean, Jasper?
Oh, when you're injured, you panic. First thing. Something hurts. What's going to happen now? What does this mean?
Yeah. So what's going to happen in the long term or the short term or both?
Both.
Both, absolutely.
Basically, I'm injured. Now what?
Yeah, exactly. Oh, nice. I like that. Anything else? Anything else? Okay, so there's a journey that every injured athlete goes through, okay? The first thing they want to do is understand their injury and understand their pain. So like what's going on. Cool? That's the first thing. And that's probably where panic sets in. The next things they want to do is reduce their pain. They want to continue training with no interruption. And they want to be able to tackle the pain if it ever comes again. So they want the knowledge. So this is how I'm going to kind of base my talk on. Kind of go through each step of the journey of an injured athlete. So the first thing we need to do is understand what is pain. Sorry, the first half of the talk is a bit wishy-washy, but it makes sense all in the end, don't you worry. So, does anyone have a definition for pain? Can anyone describe what pain is?
It's a signal.
It's a signal. What do you mean by that, Jasper?
It's like the brain's way of telling me, oh, I might be in danger. So it's like a feedback.
Nice. I like the word that you put there, might be in danger. That's an important part. Does anyone else have a definition?
It's protective.
It's a protective thing. Yeah, nice. So there's loads of definitions of pain out there. Okay, and the two kind of ones that I think sum it up the best is an unpleasant experience associated with actual or potential tissue damage, or the perception of a threat that doesn't always equal tissue damage. So what's kind of the common theme with those two definitions?
It's not always damage.
It's not always damage, and that's the point I want to really put across to you guys. 20, 30 years ago, when we thought about pain, we were like, something's wrong, I need to fix it. That definition slowly changing to there could be something going wrong, there could not be, okay? So research shows if I got a dumbbell, okay, and I went across the whole room and I dropped that dumbbell from the same height onto your foot, same weight to all of you guys would give me a different pain score out of 100, okay? I'm giving you guys the same stimulus, the same weight, the same height, the same foot even, okay? But you'll all give me a different pain score. So that tells us, that ties back into the definition that, you know, it's not directly proportional. It's not the same as what's going on. There's other factors involved. So this is quite a nice metaphor. Pain's like a fire alarm. When a fire alarm goes off, it doesn't tell you where the fire is. It doesn't tell you how bad the fire is. And it doesn't necessarily tell you if there is a fire in the first place. But it tells you that something's wrong. And that's what pain is. Pain's telling you that something's wrong. And going back to it, we can spin it. It's beneficial for us because it means that there's loads of factors that is feeding into pain, and we can do something about that. It's not always anatomical abnormalities, okay? It's not always something that's wrong. So to go a bit geeky, okay, there's two models of pain. The one that we used to use a long time ago, and the new model of pain. So the biomechanical model of pain, the biomechanical model of pain is, we liken it to a car. Back in the day, we used to think if a car broke down, there was a part that was broken, and we need to fix that part. We now have a new model of pain, which is the biopsychosocial model of pain, which tries to kind of summarize those previous definitions I had. That there's loads of factors that are feeding into our perception of pain. Okay, so Abdal, come on man, why are you telling me so much about pain? Why do I need to know about this? Well, educating yourself about pain is really important. This model, so it's called the fear avoidance model, was developed to kind of understand why do people with acute lower back pain end up having chronic lower back pain. And it said that when you're injured, when you're hurt, you go one of two ways. You either start catastrophizing, which someone said over there. And when you start catastrophizing, you start avoiding things. When you start avoiding things, so you start avoiding, for example, if your back hurts, you start avoiding deadlifts. You start causing yourself disuse. Your muscles atrophy, you lose your movement patterns. And that then feeds back into your pain experience. It makes it worse. The second way we can perceive pain is we're like, okay, cool, stay calm. I'm hurt. Let me do something about it. You have low fear. You confront the pain and you start recovering, okay? So I get a lot of athletes who are stuck in this cycle, who have tried for 2-3 months, who are really scared of deadlifting again with back pain. So we need to get them out of that we need to get out of that cycle and get them on the road to recovery. So what do we know so far? The concept of pain is probably as complicated as my wife, okay? Shout out to my wife who's in the back. So I'm going to do a bit of myth busting, okay? So yeah, the guy at the gym said to me. So yeah, but the guy at the gym said to me, if you're hurting more today, that's probably because you've got more damage. Well, like we've just talked about, the biopsychosocial model of pain tells us that there's loads of factors that are feeding into it. So it's not always how badly you're hurt. Yeah, but the guy told me, if my knees cave in, I'm going to get knee pain. Has anyone seen, it's Amanda Lawrence. Has anyone seen Amanda Lawrence squat? Have you seen how much her knees cave in? Her body is adapted to that. It might not be the most efficient way of lifting, but it's not necessarily gonna cause a knee pain. Same with deadlift panda. Has anyone seen how much he rounds his lower back? Same thing. It might not be the most efficient way, but his body's adapted to it. If he does end up getting lower back pain, there's stuff that we can sort out. But at the moment, it's fine. Okay, this is probably a big one. Oh, bro, just rest. You'll get better. No, we've already talked about that. If you rest, you cause your body to go into a state of disuse. You lose your adaptations, and you actually end up feeling pain more. This is my favorite one. Don't worry, just stretch it off. It'll be fine. Just carry on stretching. Foam roll for half an hour. It'll be fine. And I could actually give a complete whole other talk on stretching, but I'll go through the main points. Research tells us that stretching only causes a temporary relief. Only gives you about 20 to 30 minutes of, I'm going to use a scientific word here, proprioceptive change. Proprioceptive change just means how you feel when moving. Okay? So, how does it do that? Another big word, neurophysiological effects. All it does is it changes mediators in your spinal cord and your brain to make you feel different when you're moving. Okay? I want to really hammer this point in. It does not create permanent change. Research shows that you need around 1,000 pounds of weight to change your IT band. Everyone must have stretched the IT band at least once in their life. Okay? Yeah, I've got knee pain, I need to stretch my IT band. Takes about 1,000 pounds, that's 500 kilos to change your IT band by 1%. That's research. So you cannot, unless you've got a steamroller on you, you're not changing your fascia around your muscle. Okay? But it does create temporary relief. And I'll come back to how we're going to use stretching as kind of a tool rather than a silver bullet. And another thing that people might not realize is that the dose needs to increase every time to get the same desired effect. So to get the same ankle mobility that you did when you just started your powerlifting career, let's say it took you 10 minutes to stretch your ankle, 2 years down the line, if you've been stretching your ankle on a daily basis, you're going to need more time to get the same effect. I want you guys to understand, when you're not injured, okay, you don't need to be spending 30 to 40 minutes stretching, okay? Just because you've been stretching when you started, or just because you stretch your ankles when you just started lifting to hit depth, doesn't mean you need that now. 2 years down the line, your body will be adapted to hit those positions. So you only really need active stretching rather than static stretching to get into that position. Number two is you also need tightness in the right areas as a powerlifter. When you squat and you're in the bottom of the squat, you want to feel stable and you want to feel tight in there. If you're continuing to stretch your hip flexors, you're going to lose that stability and you're bringing down your performance. Research proves that. There's loads of studies that show that static stretching actually ends up having a negative impact on athletic performance. Okay, and for all of you geeks out there, I've referenced all my slides to all the research, okay? But when you're injured, it is useful, and I'll come back to how we're going to use it. Okay, my back hurts. I'll get an x-ray, I'll know exactly what's going on. This is counterintuitive, I know. I'm a doctor, I x-ray everything, okay? But for you guys who are a healthy population of athletes, you don't need, unless you've got a bone sticking out or your knee is pointing the wrong way, you don't need to get imaged, okay? If I was to image, let's say I was going to do a full body x-ray on all of you over here. None of you, I assume, let's say you're all healthy. You guys might have injuries at the moment, but let's say you're all healthy and I was to image all of you guys. 2/5 of you will have something wrong in your back on imaging, even though you've got no pain. I think the figure was around 40 to 50% will have something wrong in their knee. And for you slightly older lot, who are in their 30s plus, nearly all of you will have something wrong in your shoulder. But you're not feeling pain. So what does that tell us? That structural damage doesn't always cause pain. So you don't need imaging unless there's something, because it's not going to change the way we're going to rehab you in powerlifting. It's not going to change the way we're going to do that, okay? Unless I've got to put a caveat. Unless you've got red flag symptoms, for example, for back pain, then yes, obviously get imaging. But generally, there's nothing going wrong. Don't let your lower back round. I'm not talking about the actual act of lower back rounding, I'm talking about the language. When people tell you don't let your knees cave in, don't let your lower back round. Language is important. People learn about pain in two ways. Direct experience and indirect experience. Direct experience is if I punch you and you feel the pain, that's a direct experience. Indirect experience is if I tell you, if you're going to lift like that, you're going to hurt your back. So it's through talking. Research tells us that if you have someone who's injured and you give them positive language, you use positive language with them, they're going to feel that pain less. Okay? So it's really important when I get an injured athlete who comes to me, the first thing I don't say to them is, I'm going to have to take about 12 weeks, you're really badly hurt, you're going to take 12 weeks to get better. You need to give them positive reinforcement. Okay? So there's three types of athletes in this world. Okay? After all of this. There's the first one who either didn't come to this talk or didn't listen. Okay? Who when they get hurt, they think it's damaged. They start getting fear. They avoid. They rest themselves. They avoid the lifting. And, sorry if you can't read it in the back, they become deconditioned. And they feel the pain worse. There's a second type of athlete who's the dumb athlete, who gets hurt and thinks it's a sign of weakness and continues to ignore the pain, continues to train, and ends up worse off. And then there's the third type of athlete, the one that either came here or is educated themselves with pain and understands its multiple factors, understands that they need to educate themselves, understands how to train smart and does something about it, and takes it head on, and actually doesn't end up going backwards, but ends up being in a better place than they were before they were injured. So we've done this first part. We understand pain, we understand injury. You'd be like, Abdul, come on, man, you've talked a lot about soft stuff. Okay, yeah, I'll be really nice to people when I talk to them. I won't tell them to get an x-ray. But what do we do practically when we're injured? That's what we're going to talk about now. So I thought the easiest way to go about it is going through a case study. Okay, this is someone I worked with. He was a 20-year-old who was getting ready for World Championships, and he hurt his lower back around 12 weeks out from World Uni Championships. So the first thing we had to do was find an entry point into training. Okay, so if you open your leaflets, this is kind of the bottom right-hand corner. This is the first pillar that I look at when I have an injured athlete who comes to me. Is how are we gonna modify their training so that they can continue training? So we find an entry point. So the first thing we do is we establish painful movements. What movements is this person sensitive in? What's hurting? And we use screening tools, okay? So there's a whole host of screening tools. For Dan, his name was Dan O'Leary, the case study. He had lower back pain, so we found out what was he painful in. Was he painful in flexion, or was he painful in extension? So either pushing your bum out or curling your bum in. Then, once we found out what was hurting, we followed this kind of hierarchy, okay, of modifying his training. The first thing we do is decrease external load. We decrease the actual load that the person is lifting. Does that help? Make them lift less. If that doesn't help, we then move to changing the range of motion on the painful movements. So for Dan, for example, his deadlifts were painful off the ground. Fine. Lifting less didn't work? Fine. We'll remove the lower portion of the deadlift. We'll go for block pulls. Okay, so at least he's continuing to train. If that doesn't work, we'll change the exercise altogether. We'll put in another hip hinge exercise, for example, weighted pull-throughs, so that he's getting a similar motor pattern, but it's removing that painful exercise. We then add in some unilateral and bilateral work. So if I'm removing a portion of the exercise, or I'm changing the exercise altogether, some of his muscles won't be getting the same stimulus as they normally once were. So for example, if I get someone who's got pec tendonitis, their pec's hurting on the bench press, and we've reduced their volume and we're doing block press, for example, they're not getting the full range of motion in their pecs. So I'll add in some push-ups, just so that they're working the whole pec muscle. So we're still getting some volume in a different way. So load management. this feeds back into this slide. So we need to manage their load somehow. Now, there's two types of load. External load, which is what you're actually putting on the bar, and internal load. And we all have probably worked with internal load. It's rating of perceived exertion, RPEs, okay? Or RIR, try to say that quickly. But yeah. Now, research has proven the link between loading and musculoskeletal injury. And what is that link? Is that our tissue has a tolerance, okay? We all have a tolerance. For some reason, if that tolerance, tissue has tolerance, and this is where we're normally training, okay? We're normally training underneath that tolerance. We haven't breached the tolerance, okay? For some reason, our tissue tolerance goes down, whether that be poor sleep, you're not feeling happy at your job, just broken up, or you've literally just been training loads, okay? You've just not recovered properly. Once you breach that, that's probably when you start feeling pain, okay? So we need to manage this. We need to manage load. And I really concentrate on internal load. So how is the athlete feeling? Because it's subjective. Sometimes you don't want subjectivity, but it's really important in an injured athlete because it tells us external load can't take into account all these other factors. How you've slept, how your nutrition's been, all that kind of stuff. But internal load can. So we really concentrate on RPE work so that it takes into account all these factors. This is an acute chronic workload ratio. Does anyone, any of the coaches familiar with this? No? Okay. So let's say I'm doing 10 sets of squats this week. Okay. Next week, I do 12 sets of squats. That's a 1.2 ratio. This is from a research paper. It's really good. Darren, I haven't linked it. I'm sorry. It's the previous slide. That's a 1.2 ratio. That's a sweet spot. We're unlikely to get injured in that area. Okay. Let's say I'm doing an RP 5 set today. I just go next week. The music's sick. I've got all my mates. I'm gonna go RP 10. I'm gonna go ham. Okay. You're putting yourself into the danger zone. You're putting yourself into kind of an injury risk zone. And I'm not necessarily saying if you always train in that high risk zone, you're gonna get injured. Okay. Because sometimes you're required to do so. But I'm just saying that when other things are not going well, you can put yourself at risk. Cool. So we've talked about what we can do with modifying training. We also need to really look at recovery. Okay? Remember I said you want to continue, you want the athlete to continue to train, right? You want them to continue to train so that if they're feeling good, they're maintaining adaptation. So we need to find like what I call a baseline pain-free volume. How much volume can this person take where they're pain-free and they can continue to train? What does that allow us to do? That allows us to train. It allows us to minimize fear avoidance. It allows us to minimize pain sensitization, so how badly you're feeling the pain. And it allows us to unload that painful tissue, okay? Once we found that baseline pain-free volume, we start building on that. We start reloading that tissue. But how do we do it? Okay, there's a model, there's the pain analysis model. How do we know that, you know what, I've got a little bit of pain. Is it okay for me to continue training or do I need to stop altogether? So I give my athletes two categories that they can put their pain into. Okay pain and be careful pain. Okay pain is a less than 3 out of 10 pain. Okay, it's less than 3 out of 10, 10 being the worst pain you've ever felt, 0 being no pain whatsoever. Why? Why do we accept any pain whatsoever? Because at the end of the day, we're athletes, okay? Or we like to think we're athletes. We're athletes, and when we're training, we're always going to have a few niggles here and there. If we're going to stop every session when we have a niggle, we're never going to train, okay? So allowing a little bit of room for a little bit of niggle is okay. Less than 3 out of 10 pain is fine because it doesn't necessarily mean that something's going wrong, okay? What else is okay pain? Okay pain is pain that doesn't get worse after a session and doesn't linger after 24 hours. Okay? If my athlete is feeling that every session, I'm happy, I'm going to continue progressing them. I'm going to continue reloading that tissue. They're going to progress to normal training. If they land into this be careful pain, that's anything above a 3 out of 10, anything that gets worse with a session, or anything that lingers for 24 hours or more, we're going to redo that. We're going to change something in their training. Are you guys with me so far? Good. Lots of nods. Other things we look at in recovery is nutrition. Guys, I'm really sorry. If you're injured, you can't cut. Don't cut, okay? We need to give your body the fuel to recover, okay? There's small amount of research that tells us that higher fat diets help with injured athletes. And I've seen it work with my athletes, both from an actual biological level, but also because at the end of the day, taste is carried in fat, okay? So if your food is tastier with higher fat meals, you'll feel better. It will make you just feel better, okay? Do you guys get what I mean? Good. And protein's high. And the last thing, we all know how brilliant sleep is. Guys, when you're injured, you really need to focus on your sleep. There's a great book, Why We Sleep, if anyone's read it, okay? Highly recommend it, but it affects a lot of things, okay? So, what do I get my athletes to think about in training? I get them to think about 3 things. How does it feel? How's my form? And what's the intensity? So how it's feeling is going back to that pain analysis. You know, what is it, okay pain, or is it be careful pain? Is it less than 3 out of 10, or is it above 3 out of 10? Next thing I get them to think about is their form. Am I maintaining form? Okay. I did say that bad form doesn't always equate to bad movement, but when you're injured, we try to remove as much variables as possible. And finally, am I working to the prescribed RPE? Remember we were talking about internal load and how important internal load is when you're injured, because it's subjective, okay? So am I doing the right intensity? Fine. Third pillar of rehab is efficient movement. It's in your booklet. I think I bashed stretching enough, but I did say that it is a useful tool when you're injured. Why? Because it gives you temporary relief. It allows you to get into training with slightly less pain than you would have done without doing all this stuff. I'm not telling you to go for an hour ham, because it's just not going to be beneficial. But causing some change, some proprioceptive change, will allow us to then start training pain-free for that session. Okay? So it's the right tool in the right context. We then mobilize the joint. Pain inhibits mobility of a joint. So we start mobilizing that joint so that we can get the full range of motion, the right movement pattern back into what's painful. We then stabilize it. So this is a really nice hierarchy, okay? So we mobilize it, we then stabilize the joint or wherever it's feeling painful, because that gives you an actual feeling of stability and it gives you a psychological feeling of stability. Okay? So if you've got back pain and you stabilize your core, you feel that your spine is actually more stable in in a real term setting, but you also feel more stable. And then we start strengthening with normal training. This was funny. Back, I think it was about 2015 time, the whole hype was PRI. PRI is really, it's like the golden bullet. It's like stretching. It's not the silver bullet, but it's good to make people aware of the muscles they're not using. Does everyone know what PRI is before I carry on? No. Have you ever heard the phrase, do these booty band exercises so you can activate your glutes? Come on, everyone knows that, right? So that's this form of PRI exercises. And it's good in the sense, but it's a good tool in the right context. You don't need to do it. If you have been squatting for 6 months or 10 months, you are probably using your glutes. You don't need to booty band for 30 minutes to use your glutes, okay? And then finally, technique analysis. And this is just an example of that this is cheating and this is not. No, I'm joking. You can deadlift in different ways, and you work with the athlete to analyze their technique. We don't go when a person is injured. We don't try to concentrate too much on technique. We just make sure that they're moving efficiently and work on other things. Finally, stress management. I thought this is probably one of the most important things in rehab, is managing the person's stress, because Going back to the biopsychosocial model of pain, biological elements is 1/3 of that. There's a psychological and a social element to our feeling of pain. So we've talked about the fear avoidance model. And what I do is I change the negative into the positive. If someone has got back pain and they can't deadlift, we get them to change that into a positive. We're like, let's blow up your bench. Let's do something else. Okay? Whilst we're rehabbing your deadlift, let's do something else. And that way they start looking forward to training. We make long-term goals into short-term goals. Okay? So I think, Jasper, you were saying that when you get injured, you're like, how long am I going to be out for? Okay? So we funnel that long-term perspective for an athlete into a short-term perspective. Don't worry, what we're going to achieve this week, okay? And we do that every week so that the person has something to look forward to, knows what they need to achieve. And we kind of use SMART goals. Guys, if you don't know what a SMART goal is, you're not doing university properly, okay? They love to drum this down, okay? And finally, we'll talk about self-monitoring, relaxation. I don't need to drum this down. There's a lot of mindfulness. Everyone knows about it, how beneficial it is. I get my athletes to pick a relaxation method and I make sure that they're doing it because it's really beneficial for them. Self-talk and imagery. We must have all seen athletes, for example, before running the 100 meters. They're talking to themselves. They're imagining themselves winning the race. And we're no different. We're athletes. We should be doing the same thing, especially for injured athletes. Bryce Lewis came up with this. Does everyone know who Bryce Lewis is? Good. He came up with this 3-step type of mantra to self-talk. The first thing he does, and I've adapted this for injured athletes. The first thing he does is he reminds himself of the standard of lifter he is. So for an injured athlete, I get them to tell themselves, okay, if they've got an injured back, for example, I can deadlift 200 kilos. I know how to deadlift 200 kilos. This is a set of 120. I've done this 100 times before. So they've reminded themselves the standard they are. They then tell themselves a cue. So pull the slack out of the bar or whatever you're working on that week. Okay. And then the third thing to do is turn the negative into positive. So my back is strong enough to lift this weight. So you're telling yourself that, you know what? I know my back's hurting, but my back is strong enough. And you put that together. You kind of write it on your phone and you change it every 4 weeks. Okay? And it's really good. You're telling yourself that, you know what, a positive self-talk, I will be able to do this. Expectation management is really important in an injured athlete. Okay? And the most important one is predicted expectations. What the person believes will occur. And that comes down to the coach. You need to help them have the right predicted expectation. You need to make sure that you're giving them a realistic goal. If someone's got hurt their back, you're not going to tell them that, dude, don't worry, you'll be back to deadlifting 300 kilos tomorrow. Just do this stretch. You're not going to tell them that. You're going to give them a realistic expectation. It's going to take around 4 weeks, but don't worry. So, going back to the case study, what did I do with Dan O'Leary when he hurt his back? Okay, so week 0, he was deadlifting 12 sets and his average pain was 7 out of 10. So I was like, cool. We decreased the external load. We were getting to deadlift lower weights, didn't work. So I was like, fine, we're going to change the range of motion. Remember on that, if you guys open your booklet on the, I think it's the bottom right, where it says, change load, alter range of motion, change exercise. So we went to step 2. We altered the range of motion. We had above the knee deadlifts because the off the floor was hurting him. And we put in some rope pull-throughs, which was the unilateral, bilateral work. So what change did we do? We split up the deadlift volume. We removed the range of motion off the floor. And we put in some cable pull-throughs so that he could still get some adaptation for his lower back. So week 1, he was doing that. His average pain score went down to about a 5. So it's still in the be careful limit. Okay? So we need to change something else. So what we did was, we decreased the volume. So we were like, okay, fine, the altered range of motion is working. Let's decrease the volume. Let's see what happens to his pain score. Week 2, same decreased volume. His average pain score was 2. So that's good pain. That's okay pain. So what did we do? We increased the RP. We're now going to give our athlete some progression because that gives them something to look forward to. Okay? And also, it's 2 out of 10 pain. It's fine. We can give them some progression, see how their body reacts to that. Week 3, his average pain score was 2. What was the change? Increase RP. Eventually, so what will happen eventually is once he's done a block, normally how I do it with my athletes, I get them to start with an RP 5 or 6. After 4 weeks with a bit of manipulating, if they're still below a 2 out of 10, we're going to slowly get him back to full range of motion. That's what we're going to do. So probably week 5 was introducing some off the floor deadlifts. See how his body reacts to that. This is kind of the landing sheet, the rehab landing sheet that we have for our athletes at Barbell Coalition. Okay. I have my coach's impression, painful movements, what their baseline volume is. Then I get them to write their current injury mindset so that we can work on it together, change the negative into the positive. We get them to write down their positive affirmation, the Bryce Lewis thing. Smart goals. So we change that every week. Every weekly check-in, we're like, okay, fine, what's your next week's goal? What's your next week's goal? Chosen relaxation technique, self-talk, and then some technique points to work on. Remember, it's not the be-all and end-all. Volume recommendations, change to compound movements, which is changing your range of motion, and accessory movements. So thank you guys for listening. So what's your takeaways? Okay, for an athlete, nip it in the bud early. The longer you leave it, the longer it's going to take to rehab. Okay? Educate yourself, and you've already done that by coming to this talk, so well done. But educate yourself. And remember, progression isn't linear. Just like when you're not injured, you can't keep on adding 5 kilos onto the bar, okay? Unless you're a newbie or unless you're Hamza Bam. But you can't. Progression isn't linear, and rehab's the same. Pain scores are going to fluctuate. They're going to go up and down. And as a coach, my role and responsibility is to make sure that the athlete understands that, okay? Remember to manage your expectations. And I'm biased here. If it's still not working, get yourself someone who understands pain science so that they can work with you. What's the takeaway for coaches? Remember to have programming and RPE considerations. Remember to look at different load management strategies. So we were talking about internal and external load earlier. Look at what you can modify in their training and just their day-to-day life. Start utilizing some linear progression for rehab. So that's when we were going back to the example. I got Dan O'Leary to go from an RP5 to RP6 to RP7. Utilize that with the person who's rehabbing. And finally, utilize positive language for your athletes. Okay? Guys, thank you so much for listening. Any questions? Fire away. Yeah, go on, Hamza.
How long would it be okay to train with okay pain?
As long as you want.
Okay.
So you, as long as that pain isn't above a 3 out of 10, isn't stopping you from doing your session, isn't getting worse after a session, isn't lingering for 24 hours, you can continue to train. Because you're an athlete, you're going to have niggles. If it's not your elbow, it's your knee. If it's not your knee, it's your back. If we're going to stop at every time you have a niggle, you're not going to be training. Okay? So we need to have a bit of a cushion. And that 3 out of 10 is perfect because it should be pain that isn't stopping you from doing what you need to do. Do you get what I mean? Cool. Any other questions?
What are your thoughts on stretching pre and post a training session? Like, what would you recommend?
So 2 questions. So is this for an injured athlete or a non-injured athlete?
Both.
Okay. And is this static stretching or active stretching? You're going to say both, aren't you? Okay, lovely. Okay, for an uninjured athlete, what I recommend is, what I recommend is you look at your training. You work out what do you need to do. Let's say you've got someone who can't hit depth, for example. Utilize static stretching for around, I think the research shows, I think the sweet spot's about 10 minutes. Okay. But the main thing you need to take away is every 4 weeks, change that. Because after around 4 weeks, your body should be adapted, or even 2 months, your body should be adapted to hitting that new position. Do you get what I mean? You will have gained that new range of motion, so change it up. Because if you keep on doing the same thing, like I said earlier, you're gonna need more and more and more to get the same dose. Okay. what I normally recommend is like spend 5 to 10 minutes on an on passive stretching, static stretching, and then do an active stretch. So have you ever seen a barbell complex? Just do a barbell complex. So that's like RDLs into hang cleans, into back squats, into good mornings, right? And then Barbell Medicine have a really good article on it, is just do more unweighted warm-up sets, because eventually your body will be warm enough, and when you start adding load on the bar, you'll get into the positions you need. Okay, so that's for an uninjured athlete. For an injured athlete, you use enough stretching to give yourself that proprioceptive change. You know the proprioceptive change we were talking about, how you feel when you're moving, to give yourself enough to start training with a 3 out of 10 pain. So let's say you've got a pain in your glute, you can get a lacrosse ball, just roll on it for a little bit until you start feeling a little bit good and start doing your active stretching. Okay, and if that doesn't work, you need to change something else. But again, I don't like my athletes spending longer than 20 minutes because you've got other stuff to do and you want to start training. If you're going to spend an hour stretching, you're already tired and you spent 3 hours in the gym. Some of you guys might like it, but I want to go in and out. Cool. Any other questions? No? So you guys are going to go away, you know, you're never going to come back injured again? Good. Guys, thank you so much for listening, honestly.